Yes.
Okay, good evening, everybody. I know many people are still in the waiting room, waiting to join, but because of the time constraints, so I will start the introduction part first. So this is our fourth APHOG, which stands for Asian Pediatric Hematology Oncology Group, and also SIOP Asia Joint Scientific Symposium. And this is the fourth time that we combine together. So the APHOG is the clinical trial arms of the Asian oncology experts. On which South Asia is more on the training and education. Of course, we have some overlap activity, but most of us are together. And then today, it is our honor. We have our APHOG chairman, Professor Akira Nakagawara with us. And then I know Professor Yuo from Armenia, our new South Asia president, will join us later on. So we will have a very fruitful, I can guarantee you, because we got the many outstanding experts in the field of retinoblastoma to share their knowledge with us tonight. So without further ado, Akira and Giwa is not here. So Akira, can you give some opening remark? Giwa is here now. So Akira, then Giwa.
Okay. Thank you, Godfrey, for introducing me. So also thank you everybody for participating the APHOG and the South Asia Joint Scientific Symposium 2024. So APHOG stands for Asian Pediatric Hematology and Oncology Group, and is a clinical study group of childhood cancer in Asia, as Godfrey already said. So APHOG was officially founded in 2021, 3 years ago, but its initial kickoff meeting goes back to 2012, actually 12 years ago. So Asia is very large and occupies about 60% of world population, including many low and middle income countries, where the cure rate of childhood cancer is still very poor. So therefore, APHOG and SIOP Asia decided to work together to increase the cure rate and better care for the children with cancer in Asia, just like two fields of a cart, a Chinese proverb. So in addition, recently, we decided to collaborate with the POEM group, Pediatric Oncology, East and Mediterranean, led by Professor Gebal. The theme of this year is retinoblastoma. Please enjoy the symposium. Thank you.
Giwa, Tamamayan, it's your time to give our SIOP Asia president currently. Can you give opening remarks to our audience?
Yes, sure. Thank you very much, Dr. Godfrey. Thanks for the introduction. Thank you very much, Professor Nakagawara, for the invitation to join today. It's a great honor and pleasure to give a welcome remark on behalf of SIOP Asia and POEM groups. As you already mentioned, we are closely working together between SIOP Asia, APHOG, and now also POEM to increase the survival rates of kids with cancer in Asian region, which is currently not currently, but in general, is the largest and most populated continent in the world. So I'm sure we'll have a lot of collaboration in the coming years, and I'm pretty sure that we'll be able to move forward with every step. And thank you very much to all the speakers and our president, Professor Shantada and other all distinguished speakers and the SIOP office for making this happen. And first of all, also thank you very much, Professor Nakagawara, for organizing this and having us. Thank you.
Thank you. So now Professor Mohamed Sajid Khan will introduce our first speaker.
Thank you so much, Godfrey. Thank you, Kira, for organizing all this, and APHOG and SIOP office for conducting these all activities, the 4th symposium. So I really feel privileged to introduce Dr. Guillermo Chantada, who is a pediatric oncologist, pediatric hematologist and oncologist. He started his career in Buenos Aires, and then he's very much renowned several years for being the editor-in-chief of Oncopedia of Cure for Kids. Everyone knows it's one of the most famous portal for dissemination of pediatric oncology knowledge. So since 2013, he is working as in Barcelona as a head of Pediatric Cancer Center Barcelona Outreach Program. And also he's working in Uruguay and as a director of a scientific director of the Hematology Oncology Service. The most recent and the most important feather in his hat is the president of International Society of Pediatric Oncology. And you know, SIOP has prospered a lot of advancement under his leadership. His most area of interest is the retinoblastoma, a lot of research and a lot of things, and he's renowned since long time. I remember in 2012, we conducted a meeting in Pakistan and we invited him as an online speaker. So he's really an expert in that field, and I'm really privileged to invite Dr. Guillermo to talk on the first talk on this virtual webinar. The topic is challenges of global cure for retinoblastoma. So Guillermo, floor is yours.
Thank you very much, Sagir. Thank you very much, dear friends. It's a great privilege to be sharing time with you, and thanks for the invitation. I really enjoy very much the meetings and the work that is being done by APHOG and SIOP Asia in general. So it's really a privilege for me when I am invited to talk about retinoblastoma, which is the tumor that I did most of my research and my activities. I'm still doing, and I'm still trying to do in my career. So let us talk about the challenges for the global cure of retinoblastoma. And first, let me start by this sketch that we did with Scott Howard many years ago, and we updated, showing that there is a survival gap in retinoblastoma, like in many other tumors, by the way. It's not a surprise that the survival of retinoblastoma is different around the world, and that is different regarding the country where you live. If your country is a high-income country, mostly in Europe and Japan and the US and Canada, the survival rate, as you see here, was over 95% decades ago. So the cure of retinoblastoma is not dependent on extremely new treatments and modalities or diagnostic modalities. It was cured already 40, 50 years ago, most of the time. So that's the paradox, because this is a curable tumor that can be cured simply by enucleation or by preserving the eye, in some cases with bilateral disease, but still in low and middle income countries, we cannot cure this curable tumor. So in this chart, you see, it is quite schematic, but you see that most upper middle income countries, I am originally from Argentina, and I did most of my research in Argentina. When I started doing retinoblastoma in the late 80s, our survival rate was around 80%, and it's published. Now, the latest Gallup, the Latin America Gallup is the equivalent to APHOG in Latin America. The latest protocol is 98% survival rate. So we could do it in upper middle income countries. I think low middle income countries are going very, very fast. I know many of the Asian countries are there in this group of countries, and hopefully the low income countries will catch up. And you know, retinoblastoma is one of the tumors that was selected by the WHO to become curable in 60% of the children worldwide. So we have a great challenge. We have to move up at least to 60%. This is my hopeful slide. So you see this curve for the low-income countries where I try to put it near 60%. And we hope that we can reach that. And let me, this talk will be how, first an analysis of the situation and then some practical tips so we can think what is best that we can do to really close this gap. Like in 2010, we did a very interesting study that was published in British Journal of Ophthalmology, where we tried to, we did an analysis, a meta-analysis of published studies in low and middle income countries on retinoblastoma, and we found there is a big inequity. It's, again, not a surprise, but you will see that survival rates are related to the Human Development Index of the country, also related to the maternal mortality rate, and not so much in the health expenditure of the country. That, again, emphasized that it's not that you need a very sophisticated health system. You just need early diagnosis. You need to get there on time. You need the families to accept the treatment. And you don't need CAR T cells. You don't need transplants. You don't need immunotherapy. With very simple things, you can improve the results. Also, we took a close look in a word that I don't like too much, but is for simplicity, let's talk about abandonment or poor compliance to accepted treatments by the families. So they are also related with Human Development Index, also related to infant mortality, and a little bit more related to health expenditure. So probably money that the government could invest in the health system would reduce the abandonment rate probably first. Later, this is a really great study that was done by Didi Fabian, who did this extremely great study in more than 4,000 of patients around the world, trying to put a prospective number on our observations like 10 years earlier, and he found exactly the same. You see this gap is really big in the low-income countries compared to the high-income countries. This is probably an overestimation of survival in high-income countries. His numbers, in low-income countries, his numbers are around 50%. Probably, we all think that this figure is even lower. And why do these children die in low-income countries compared to high-income countries? In high-income countries, this is also part of our study back in 2010. Dr. Sherife Canturk did this study. She's from Turkey. And in high-income countries, the major cause of death is second malignancies, like probably it's in Japan. And you see very few cases, very few children that die of extraocular relapse, virtually no toxic deaths, and virtually no abandonment. It's really uncommon to see a child whose family don't accept the treatment. In middle-income countries, still extraocular relapse is, at least when we analyze that, like 14 years ago, is still the #1 cause of mortality. So we still need to design better treatments there. We still have the issue of abandonment on around 5% in that study. And toxic deaths, because patients come with more advanced disease, we have to use more intensive treatments. And we have not such a great support like in high-income countries. So toxic deaths are still a problem so treatment-related mortality is still a problem in middle-income countries. Of course, those who survive are at risk of second malignancies, and it's also a cause of death. But we don't have the data for 40 years or survivors for 40 years in most middle-income countries. So we are probably going to see that in the future, and this graph will change to adapt to that. So this is in the mortality that we are seeing now. And what happens in low-income countries? In low-income countries, abandonment of treatment is one of the most frequent cause of death, because these are curable children, most of them, that are diagnosed when they are in intraocular stage. Enucleation is usually recommended. The families don't accept children. The family take the child back to their community, come back a few months later. You know better than me this problem with extraocular disease, and then die. Toxic deaths are still also present, not so much like in middle-income countries, maybe because high-intensity treatments are not so used, because in these settings it's not possible. And of course, extraocular relapse for those that could be enucleated and then sometimes couldn't receive the treatment adapted to the pathology, and then these children die of extraocular disease. Or those children presenting with extraocular disease by diagnosis also can die of that. So just to keep it simple, I think it's not a simple problem. It's a very complex problem, but there are two things that I think we can discuss for advancing the care of retinoblastoma worldwide. One is advanced disease at presentation, and the other, as I mentioned, is support treatment compliance. So what can we do to have less advanced disease at presentation? Usually, you will hear a lot about screening on retinoblastoma, going to the community, trying to pick up the cases in the community when they're still intraocular, etc. But I'd like to take a few minutes to talk about the word screening. The word screening is a strong word for epidemiologists, for cancer epidemiologists. Screening is when you go to a population, to the general population that doesn't know that they are sick, they don't have any symptoms, and you pick the disease when it's in the pre-symptomatic stage. That is what we do for breast cancer, that is what we do for cervical cancer. But retinoblastoma is very rare. It's one case in 17,000 newborns. So I tried to make an example here, which is which is still an overestimation. The blue dots will be the healthy children, the non-retinoblastoma children, and the yellow dot will be the child with retinoblastoma, and these orange dots are children with other ocular conditions. So you can, when you do screening, you can also pick other ocular conditions. So these are trying to pick the retinoblastoma cases from the community, which again, I shouldn't recommend using the word screening, where the public awareness campaigns that you all hear about are based. However, this is really a challenge. This is what, for example, we've done in Rio de Janeiro. Like a couple of months ago, you see this typical monument in Rio de Janeiro lit by the eyes were lit with leucocoria. It was a film projected about retinoblastoma. So this is what many of the groups are doing, trying to help the community to identify the cases when they are still in the intraocular case. But that is not screening. Screening will be a systematic approach to the communities. And if we try to pick a case on retinoblastoma, I just selected this image from Google, which I looked for a stadium with 17,000 people there. This stadium has 17,000 people there. So one of them will have retinoblastoma. So imagine how difficult it is. It's not like breast cancer. It's not like colon cancer. And there are rules for screening. So this is a long slide, but as I put the arrows just to see up the ones that we have on retinoblastoma, down the ones that we don't have. and the ones that are neutral are the ones that go to the right. So you see that we have only a couple of things that is up in retinoblastoma. So it is really not a tumor to screen the general population according to what we know from adults. However, in children, the situation may be different because we have, it's not like breast cancer where you can have the cancer in 20 years or in 30 years. It's that you could have retinoblastoma between the first year and the third year of life in most of the cases. So if you go to screen, you need to screen children in the very narrow population. So the only cases that it is proven that screening works are the cases that have a family history, of course, because they have 50% chance of having retinoblastoma. But also, we have to consider that if we decide to screen the population, we need to have supportive care that could support children that probably don't have retinoblastoma but were false positives. For example, anesthesia is one of them. Then you have to have safe anesthesia because the only way of diagnosis retinoblastoma is by an ocular examination under anesthesia. Suppose you have a test that is 90% accurate, like for example, the red eye reflex, you will see the sensitivity is 17% for any eye condition. It's a high specificity, but low sensitivity. So the only test that has been published for ocular diseases has very low sensitivity. So if you send a child to anesthesia in a place where anesthesia is not safe because you are in a low-income country, there are very few anesthesias, some children will die or will have sequelae from the anesthesia for a condition that they don't have. So this is a very difficult decision. And the red eye reflex, for example, is not widely tested in colored skin people, so it's probably not as effective as in white people where it has been tested. On the other hand, it's not feasible in low-income countries. You don't have the human resources to do this test. And if you try to do it with a dilated pupil to make it more effective, the toxicity of the eye drops is still not negligible. It's still not nil. You will see some even fatal cases by the use of the eye drops. So I think there is a lot of promise here in the digital photo application. So they still need validation. There are apps out there that could pick leukocoria with your cell phone. So you still need a cell phone, but probably cell phones are virtually everywhere, even in low-income countries. And probably we can really make advances here. So this is not solving the compliance, but still maybe we can pick more cases on with the digital photo application. So this is the challenge. So don't get me wrong. I'm not saying we shouldn't do early diagnosis campaign or awareness campaigns. They work, but we are not there yet to do a formal screening in the population because we have a low prevalence. If you screen 10 million children, you will pick, if you pick them all, 170 cases only. So it is really a rare disease. Safe anesthesia is usually not available. Ophthalmologists are rare. There are few ophthalmologists. They are going to spend time in seeing healthy children, have to work with their compliance with the families. The risk to other children, these families usually have 4 other children in their family, which are probably going to be not so well taken care of during this diagnostic procedure and will not affect the under 5 mortality figures, which are affected by other more prevalent tumors. So let me go back to my first slide after we talk about the first part, the left part of the screen. You see here that however it happened, we pick the yellow cases. So the yellow case is here. Now the child with leukocoria, with strabismus, is in the healthcare system. The family realized it was something. The doctors said it's something, sent to the hospital to rule out retinoblastoma. And I think this is where we should spend most of our efforts because Probably it's not a situation in Japan, but in many Asian countries, I'm sure it is the same. What we found in Latin America, Clarissa Matosinho did a very good study in Brazil, in Rio de Janeiro. Rio de Janeiro is a really wealthy city in Brazil. So the time it takes from a child with suspected retinoblastoma here to get here. So when the child first come to the hospital to the time when the child started treatment, it's about 6 months. And that is a shame. That shouldn't happen. You cannot take this long time to diagnose a child that has a curable tumor and stop. Because 6 months, it's a lot in retinoblastoma. That could mean the tumor is intraocular versus extraocular. So these indicators, time to diagnosis and time to treatment, I think they are the most important ones that we should work at the hospital, at the professional association levels with the rare tumor. How to reduce the time to diagnosis? There were some actions that were done by many of my colleagues and friends, like Carlos Leán in Mexico, for example. He did a very good education program for pediatricians and ophthalmologists. So he realized that they didn't know enough about retinoblastoma, and he did a very good program to increase their knowledge on retinoblastoma. What Helen Dimaras and Brenda Galli did in Kenya, they created the Retinoblastoma Referral Center. So when someone suspected retinoblastoma, they knew they had to send there. So it's just one place. And that place, when the patient came, did everything very promptly, just to not delay further the diagnosis. What we did in Argentina was that the hospital was the retinoblastoma center. We have one retinoblastoma center there. And the hospital took a policy where a child with suspected retinoblastoma should be a priority. So the child should be seen, if they come on Monday, should be seen the same day. The ocular examination and the anesthesia should be done the same week. And if it is, if we need to enucleate the child, that should also be done no later than 10 days. And if the child didn't have a place to stay, we have a home across the street, and the family will stay there. So in less than 10 days, we could treat that child. And that was like an urgency. So it was like you go to the OR with abdominal pain and it's a peritonitis. It's for the hospital was really an urgency. And Cancer Africa is really working very well, not just in retinoblastoma, but in other tumors as well, having unrestricted access, housing, multidisciplinary team, and an abandonment strategy. So how to reduce the time to treatment? So you have to speed up the diagnostic time. Sometimes I hear cases that you suspect the case, it was seen by the ophthalmologist, then you read the textbooks and you know, oh, we have to do an MRI. So you ask for an MRI, it takes 3 months because there is no anesthesia, there are no available slots, the family has to pay. So sometimes you can't afford that luxury. You have to operate without the MRI. So the OR time should be taken as urgent. So I know we have to compete with other specialties in a busy pediatric hospital. So they have limited time to the OR. So they will tell you, yes, I can. I have other cases that have to be operated that are more urgent. Well, we have to convince the authorities that saving a child with a curable tumor is an urgency. We cannot wait 3 months for a slot in the operating room. And again, as the MRI, we can omit non-essential tests. It is not the best thing we can do, but if we have to wait 3 months for an MRI, I will enucleate the child without an MRI. And or I try to do my best to get it in the first week or two. Very important thing, the access to drugs. Sometimes we do everything. We decide the child needs to chemotherapy, and there is no chemotherapy. There is no access to treatment. This is why the WHO and St. Jude are working on the platform for essential medicines. So no child that would need a chemotherapy will not be given the drug. So access to care is a big issue here. And of course, develop eye conservative treatments, because most of the time, especially with bilateral disease, the families will not accept enucleation, especially when it is bilateral enucleation. So you need to work with ophthalmologists, oncologists, and the hospitals to start an eye conservative treatment, because it's not because you are just going to preserve vision, which is a lot. It is because you are going to save lives, because these families will accept treatment if you offer a conservative treatment approach. And also be flexible with families that will not accept enucleation. You read in the textbooks that enucleation is the first treatment. Then if you give chemotherapy, maybe the pathology cannot be so reliable. That's okay. But if the option is the family goes away and don't accept treatment, I will give chemotherapy. And that is what we done in Central America, as we're going to see later. So you buy time, and the families can then accept enucleation when the time comes. And also, this is a multidisciplinary approach. This is not something that oncologists can do ourselves, ophthalmologists can do themselves. We have to work together here with pathologists, with geneticists, with psychosocial care. Everyone has to be on board for the success of retinoblastoma. But we also need to treat the children right. And we don't have the evidence from the high-income countries because they don't see these patients. We have to come up with our own studies. This is my experience in Argentina. This is when I started in the protocol 88. This is where we were, 85%. We were copying exactly a protocol from New York, and we had 85% survival rate. Not bad for that time. But then we started using our own protocols, and also carboplatin appeared. Probably in New York, the survival was the same in the 80s than now. But here you see how we were able to improve our results. Also, always with prospective studies. This was an old slide, but then I have the new one, which was also published. The new one is coming up, the Gallup 2 protocol, 99% event-free survival rate now. So it can be done, but we have to adapt the treatments. You cannot just copy what has been done in the US or in Europe. Also, I mentioned before, the Central American experience was really important, that they worked with St. Jude. You would see that what they did there was to give chemotherapy to those families that did not accept the enucleation up front, and they dropped the abandonment rate from 16 to 4%. That's a major survival improvement. So they went up like 12% survival, but only offering chemotherapy to the families that would not accept the enucleation, so the children will be not cured. The impact of having a center of excellence, this is what we've done in Argentina. You see here that patients treated at the tertiary care level were doing better than the rest of the hospitals. Very few of them now are treated outside the center of excellence in Argentina. I would say that 90% of the children are treated there. And let me get to the last part of the slide in the last 5 minutes I have. I will again tackle with the last part, which is abandonment of treatment, especially of curative treatment. And I think this is a big issue in retinoblastoma because the surgery is simple but mutilating. And even when it is unilateral, it is really unacceptable for many families. And we need to work very hard. And there is no one-size-fits-all solution. Sometimes, as I mentioned, chemotherapy giving first can be a solution in Central America, but not a solution in Pakistan or in Bangladesh. There may be different, or maybe in parts of Pakistan or parts in Bangladesh, just to put examples. So you need to make a full study and come up with the reasons and the solutions yourself. The first paper published about abandonment, about poor compliance in retinoblastoma, comes from Indonesia. They really did a wonderful job, Dr. Sitorus at that time, really published a landmark paper on what all we know now, what we didn't dare to report at that time. So this is, I think, a very important paper that opened the eyes to many people that say, oh, I'm seeing the same. There is a heavy influence, of course, you know much better than me, on socioeconomical issues, access to care. There are geographical variations, as I mentioned. Also, risk factors. There's a very good study that was published by Dr. Nishat a couple of years ago. Sadly, and especially in Asia, in some areas, girls are not given the option to be treated the same as boys. So this is also something that we should work on. This discrimination shouldn't happen. And it's important for statistical reasons that you, for your testing your program, you differentiate abandonment for curative therapy compared to abandonment to palliative care. Because if you have many patients with extraocular disease, a diagnosis with CNS disease, etc., and they abandon treatment, the survival will not be compromised. It is still important because they could still benefit from a good palliative care, but the opportunity to cure that child was already gone. You couldn't have cured the child, even if the family did not abandon. But the children that present with intraocular disease and then they abandon are the ones that I think we should focus for estimating the success of our programs. So let me finish with this long journey on how retinoblastoma is managed in the world, and let me give some hope of the activities that we all are doing with the cure-all package sponsored by the WHO, and where St. Jude is taking the lead. Also, SIOP is a non-state actor in official relations, and we actively participate in cure-all because this program takes all the stakeholders, all these phases that I mentioned. And if there is a program that is likely to succeed, is this one. So please join the Global Initiative for Childhood Cancer in your country if you have not already. And I stop here, and I look forward to receive any questions if there's any. I think we have to stay for the end, right? To answer the questions. Thank you very much again.
Thank you so much, Gurmaj. That's a perfect. It's a very comprehensive instructions based on your experience and expertise in low and middle income countries. Yeah, definitely. I think I have some questions in my mind, but let's keep the questions towards the end so that we can have all the talks before that. So I really appreciate for your talk. Thank you so much. So let me introduce our next speaker as Dr. Yaqub Yusuf. He's consultant ocular oncologist and head of ocular oncology unit at King Hussein Cancer Center, Amman, Jordan. He's a member of International Ocular Oncology Task Group, trained in the USA and Canada. His research focuses on retinoblastoma genetics and treatment. So he has more than 100 papers and plenty of lectures under his name. So we have his recorded talk right now to present in this meeting. So let's move to Dr. Yusuf talk, Amelia. Can you just upload that one? Thank you.
Good morning, everybody. Today, we will talk about the general guidelines for management of intraocular retinoblastoma. Retinoblastoma is the most common primary intraocular malignancy in children, and it is a disease of kids, actually. In Jordan, we see around 30 to 40 new cases every year, and the incidence of retinoblastoma is 1 out of 15,000 live births a year. Most of 2/3 of my patients are non-Jordanian, and those who have retinoblastoma from Jordan, half of them had the bilateral disease because we have more familial cases, actually. So we have a variety of patients who are coming because we have a lot of patients coming from outside the country. Those patients who are referred usually are the bilateral, so we are dealing with more bilateral patients than unilateral patients. We have a certain identified goals for management of any patient with retinoblastoma, on top of which saving life. All the decisions for treatment should be aiming to save the life of the patient. This is priority number 1. Priority number 2 is to save the eye with as much possible vision and try to avoid the side effects as much as possible in your management planning. We have multiple treatment modalities, including surgery, focal therapy, chemotherapy, and radiation therapy. The surgery that we do are usually the enucleation and the intravitreal injections. We don't do exenteration for patients with retinoblastoma. For focal treatment with tumors, we do laser treatment as TTT, transpupil thermal therapy, photocoagulation therapy by the argon 532, cryotherapy for the tumor radioactive plaque. So we have multiple options. Chemotherapy, it could be systemic chemotherapy, intravenous or intraarterial chemotherapy just to the eye, or intravitreal chemotherapy just to the vitreous, or the subterenal chemotherapy, which is not commonly used now. And radiation therapy in the forms of either external beam radiation therapy or the radioactive plaque therapy, which is considered also one of the types for focal treatment for tumors. Now, we have multiple guidelines. Let's start one by one. Guideline number 1, make sure that this is really retinoblastoma. Diagnosis of retinoblastoma is a clinical. You have a whitish vascularized intraocular lesion, but sometimes it may not be retinoblastoma. And the diagnosis clinical, you depend on many things for your diagnosis. If you have a patient like this who had retinal detachment and you cannot see the features of the tumor, look at the other eye. If the other eye had the tumor, so by default, this should be a retinoblastoma. This patient had bilateral retinoblastoma. This is easy guess. But the problem when you have, for example, a unilateral total exudative retinal detachment, the diagnosis may be difficult. For example, this patient here, and at this time you need to look at other modalities. For patient number A, there is intraocular mass or collection of something that looks yellowish in color with telangiectasia at the periphery. And the MRI here showed the retinal detachment. There is no mass, neither in T2 nor in T1. There's no masses. So what is this? This is not retinoblastoma. While on the other hand, this eye, which is very similar to this is another patient who had this total exudative RD. The B scan showed intraocular mass with calcification inside the lesion, and the MRI also showed this mass that looks in the MRI the opposite of the vitreous. In T2, it looks black. In T1, it looks white. So it is totally the opposite of vitreous. So there is mass lesion. So number A is Coats disease, and we confirm that by the fluorescein that showed the peripheral telangiectasia, while B is patient with retinoblastoma. Again, if you look here, they look very similar. Sometimes it's very difficult to distinguish clinically between retinoblastoma and Coats disease. OCT is very helpful when the tumors are very small. If you look at this eye, this is patient who is doing a screening. We saw here something whitish lesion here. Is it retinoblastoma or not? Because it is too small, you cannot tell. Do OCT, you see this intraretinal bud, but then this is retinoblastoma. So it is useful as well. After making sure that this is really retinoblastoma, we look at guideline number 2, chemo reduction. Now, chemo reduction is very important. Why? Because the tumor, now you have to put a few points in your mind. Chemo reduction is very important. Even chemotherapy alone cannot kill retinoblastoma, but it is very mandatory to make the size of the tumor as small as possible to be ready to be treated by focal therapy. Let's make it clear. Chemotherapy alone cannot kill the whole tumor. And focal therapy cannot destroy the whole tumor if it is too big. So we get the benefit of systemic chemotherapy or intraarterial chemotherapy to make the tumor as smaller as possible. Then we hit it. We hit the residual part of the tumor by focal therapy to kill it. Single or triple agents, this is huge controversy, but usually we use triple agents to decrease the tumor resistance for chemotherapy, which what we call as multi-drug resistance. Chemo reduction, this is an example of patient. This is at the presentation. We see multiple tumors. This is 1, this is 2, 3, 4. They were really big. We gave CVE, carboplatin, vincristine, etoposide. After a couple of cycles, the tumor decreased in size. Now here, you see this calcified part. it is not active, but this margin is still active. This margin here is still active, needs focal more therapy. This patient, this eye is already received more focal therapy. And the eye salvage rate actually depends on the stage. Chemotherapy is very mandatory. It kills the tumor based on the stage of the tumor. If it is too big, the chance is lower, but if it is small, the chance is higher. That's why for group A, B, C, D, the earlier the stage is, the better the prognosis and the eye salvage rate is. And I will get back to this point later on in this presentation. Guideline number 3, chemotherapy alone never be enough. You have to use focal therapy. And the focal therapy, again, I said you have to make the tumor as small as possible, then hit it by your focal therapy. If it is at the posterior pole like this one here, you can use the TTT or the argon laser, but usually use the thermal therapy by the diode 810 laser therapy. If it is very anterior, we can use a cryotherapy for the very anterior tumor. Triple freeze tau will be sufficient in most of the cases to kill a tumor. And if you have residual or recurrent single tumor, you can use radioactive plaque for such cases. Guideline number 4, thermal therapy. As I said, if for small and central tumors, either primary, if you are talking about group A tumors that are very small, or for residual tumor, if you have it like this. Now we'll talk about the cryotherapy. It is a very efficient way that can destroy the tumor, mainly the peripheral and the anterior tumors. The problem with the cryotherapy, the size of the scar will get bigger. It is very destructive, so it is very efficient to kill the tumor, but it destroys a lot of normal retina at the same time, and it can be repeated every 4 to 6 weeks. Another indication for cryotherapy is pre-chemotherapy cryotherapy, and this is very helpful way. If you do cryotherapy for the retina before the chemotherapy, this will destroy the blood-retinal barrier. This will increase the penetration of the chemotherapy, the systemic I mean, to the vitreous, so it will be theoretically more effective in killing the vitreous seeds if they exist. Guideline number 6, brachytherapy. Brachytherapy is good for medium size, but should be single tumor. It can be used for residual or solitary tumors. Very effective way, but the limitation for plaque, most of the tumors are multiple diffuse, so they don't have enough a good size, but in some cases it is very useful. Guideline number 7, don't hesitate to enucleate if indicated. Enucleation is a destructive surgery where you remove the whole eye globe with part of this optic nerve. Neither the doctor nor the family like to end with this treatment, but sometimes it is really needed because the goal of the treatment is saving life. So once there is risk for life, you have to remove it. It is the indication for advanced cases, and we will explain that later on. For failed treatment, always consider long optic nerve, because if there's optic nerve invasion, you have to remove all the gross tumor with your sample. Avoid eye perforation, because if you perforate the eye during surgery by mistake by your needle, this will cause dissemination, orbital recurrence, and distant metastasis. And always take this eye to the pathology lab to look to what we call as the high-risk pathological features. Because if you see the high-risk pathology features, which are simply the massive choroid invasion, the post-laminar optic nerve invasion, the ciliary body invasion, and the anterior chamber invasion, this indicates there is microscopic tumor that already disseminated outside the eye, either to the CSF through the optic nerve or to the blood targeting the bone marrow through the choroidal vasculature, or to the lymphatics through the anterior chamber if there is anterior chamber invasion. So you have to treat this disease by high-risk protocol of systemic chemotherapy before it gets to be disseminated and grows metastatic. Guideline number 8, try to avoid radiation, and I'm talking about the external beam radiation therapy if familial type or for a very young child. Radiation therapy is very effective to destroy the tumor, but it is associated with horrible side effects. We may use it in cases of failed chemotherapy and focal therapy, but again, it is not the good treatment that we like to use. There's very high risk of second malignancy that can get up to 50% in some cases. Second malignancy, so the patient may escape the the retinoblastoma, but they may develop another second malignancy that will cause death. It's associated with orbital deformity, APHOG before the age of 12 months. Stereotypic autism-modulated radiation therapy are modalities that can be used. Guideline number 9, which is the most important, management of patient with retinoblastoma always depends on 2 major factors. Factor number 1, it depends on the tumor group or stage. Factor number 2, on the status of the other eye. So we have to look at how advanced the tumor is and what is the status of the other eye before defining what is the best modality of treatment that we are going to use. The most commonly used classification for retinoblastoma is the international classification for intraocular RB that divides the tumor simply into 5 groups, A, B, C, D, and E. Let's make it simple and clear. Group A tumors are small tumors, smaller than 3 millimeters and far from the optic nerve or the disc, or the macula. Once the tumor is involving the macula, very close to the macula or the optic disc, or once it is bigger than 3 millimeters, it is B, it is not A anymore. Now, still we are talking, when we talk about AB, we are talking about tumor inside the retina and only inside the retina. Once the tumor started to spread outside the retina, towarding either the vitreous cavity or toward the subretinal space, it is not retinal anymore. It is either vitreal or subretinal. So we are talking about C, D, or E at this time. If this invasion was very close to the main tumor, very minimal and localized, this is group C. If this is massive and extensive and diffuse, this is group D. Total retinal detachment is considered as a group D. Now, what is worse than A, B, C, D is E. E is the eye that shows signs of destruction. The eye is already destroyed because the tumor is extensive and massive and destroyed the structure of the eye. We have characteristics for this, including irreversible neovascular glaucoma, non-infectious orbital inflammation, anterior chamber invasion, ciliary body invasion, diffuse infiltration of the retinoblastoma, massive vitreous hemorrhage, or I already said the anterior chamber invasion, and epiphysis bulbi. If you have any of these, this is group E, which is the bad eye. It is really bad eye. But again, still we are talking about intraocular retinoblastoma. How should we treat? For group E retinoblastoma, group E is for enucleation. So regardless the status of the other eye, group E eye should be removed. And we have reasons for that. Reason number 1, what is the chance to save a group E eye? It is extremely low. With too much extensive treatment for an eye that has actually no visual prognosis. So why to spend using too much chemotherapy, too much local therapy, too much radiation therapy sometimes for very long time with too much side effects to save an eye that is useless in terms of vision? And even with all of that, the chance for eye salvage is really low. It is not better than 17% in the best reported cases. This is 1. Number 2, group E eye are the eyes that had high-risk features. We have already reported that 63% of group E eyes had high-risk features, which means these are the risk eyes that may disseminate, may metastasize, and may end with death. That's why group E eye should be removed immediately, regardless the status of the other eye. Group A. Group A eye is a very small tumor, and this very small tumor is far from the optic disc or the fovea. So actually, you don't need to make it smaller by chemotherapy because it is already small. You just give focal consolidation therapy, either laser therapy or cryotherapy, depending on the location of the tumor. So group AI are the good eyes with excellent visual prognosis. Treat focally, no need for systemic chemotherapy or even intravenous chemo or intra-arterial or intravitreal chemotherapy for such groups. Or again, regardless the status of the other eye. Now, if the worst eye was group B or C, now B and C, generally they mandate chemotherapy, regardless systemic, intra-arterial, or whatever type of chemotherapy, they need chemotherapy. So if the worst eye was group B or C, you have to use chemotherapy with focal consolidation therapy for the tumor. Now, if one eye was C and one eye was B, it is chemotherapy. when I was C and when I was A, you need chemotherapy because of the CI. Even the AI, you can treat it by focal consolidation therapy. When I was B and the other I was E, you have to remove the EI, do enucleation for group EI, and try to save the group BI. Now, if it is a group D, this is the most controversial group, how to manage. Now, we are talking about general guidelines. So always we may break the guidelines depending on the family situation, the psychological impact of the family. There are too many things to consider before taking the decision for such eyes. In general, if the eye is D, DI is not very bad eye in terms of mortality. They usually do not metastasize and there's no real risk on life. The success rate is around 50% and it is getting higher with the intra-arterial chemotherapy and intraepithelial chemotherapy. But again, they need too much treatment. It is not easy. It is not piece of cake to treat a group DI. It needs a lot of treatment and still there is chance for failure. So it is expensive treatment, too much side effects of treatment, traveling, long follow-up. So you have to consider all of that when you are talking about the patient. If you have patient coming from poor country, coming to your country, and you know they cannot offer their food, you cannot ask them to pay $20,000 or $30,000 for treatment. So you have to remove the eye. While if you have a family who are living in the same country, close to you, and they are ready to come for a treatment at any time, you may offer them the treatment for this reason. So treatment for group DI depends on the status of the other eye. If the other eye doesn't mandate chemotherapy, being normal or being group A, you can do enucleation for unilateral group DI. If the other eye mandates chemotherapy, either because it was B, or C, or D, or the patient had to receive chemotherapy because the other eye was E. If the other eye mandates chemotherapy, you have to try to treat this group D because you are giving chemotherapy anyhow. If the other eye was E, you have to try to save this eye because this patient is single-eyed at this time. So if the other eye was nucleated, was group E or group B or C, you have to try to save this eye. If the other eye was normal or group A, you can do enucleation for this eye. Again, you have to customize your treatment depending on the status of the other eye and depending on the general situation of the patient and his or her family. Guideline number 5, if the best eye needs chemotherapy, don't enucleate the other eye unless it was E. For example, this eye is C, while this is D. So what should we do? We never enucleate any of them because we are giving chemotherapy anyhow. This is group DI, we don't need to enucleate it. I hope this is clear for you. For group E, intraocular tumor, don't give, now, under guideline, don't give neoadjuvant chemotherapy before enucleation. This is general guideline. If you have patient with the unilateral or bilateral retinoblastoma, and you need chemotherapy for the other eye because it's group B or C, and you have the group EI, you have to do enucleation immediately, not after giving a couple of cycles of chemotherapy. Why is that? Because, the problem for neoadjuvant chemotherapy in such cases, let's say this eye had post-terminal optic nerve invasion and massive choroid invasion, which means there is risk for metastasis in this case. And you found that the other eye was, and you gave chemotherapy. These high-risk features may disappear because of the chemotherapy that you gave. So you do enucleation, so you say, oh, that's fine. I don't see any high-risk features, so I don't need to give more chemotherapy. You stop your chemotherapy, then the patient may come with metastasis. There's a study done by John Chow in China who had showed delayed enucleation for group EIs was associated with high-risk metastasis. For familial cases, screening is a must, even in absence of genetic testing. It is very important. These are two different patients. Both of them has one of the parents who had retinoblastoma, bilateral, and they have 50% chance to have retinoblastoma. For the first one, the delivery happened at 36 weeks. For the other, delivery happened at 40 weeks. They came for screening. For screening, we found that this patient had this very small tumor in the right eye and normal left eye. How do you treat unilateral group A? Focal therapy alone, no need for anything more. Well, for the other eye, this is B and this is small A, you need chemotherapy. Both eyes could be salvaged, but the visual prognosis would be totally different. Regarding progressive or recurrent intraocular retinoblastoma, it depends on the pattern of recurrence. If it is in the retina, you need intraarterial. If it is in the vitreous, you need intravitreal. In the past, we used to use the periocular subtenon, which is not commonly used nowadays. Intraarterial is very helpful modality of treatment, very efficient because you give very high dose of systemic chemotherapy for the patient. Very effective way to give intraarterial. It will destroy the tumor, but the problem is associated with a lot of ischemic side effects in the eye, and it needs skilled person to do it. Intravitreal chemotherapy is very efficient to kill the vitreous seeds. You go inside the eye, give the injection, make sure the sequoia that you're free of any tumor before doing your injection, do cryo at the site of injection before getting the needle out, and shake the eye. The results mostly are fantastic. So retinoblastoma guidelines, we talk again, make sure it is retinoblastoma, avoid radiation if familial or young child, chemo reduction to make the tumor as small as possible, to be treated by focal consolidation therapy that is going to be either TTT or radiotherapy or brachytherapy. Don't hesitate to enucleate if indicated. Always send for pathology. Management plan depends on the tumor stage or group and the status of the other eye. And always we have hopes at the new furnitures. Thank you very much.
Right. Thank you, Dr. Yusuf. This is Rashmi Dalvi. I'm sorry for joining in late because of the daylight saving was not corrected on the flyer. This was a really excellent talk, an excellent overview of the surgical perspectives in retinoblastoma. May we now go on to our next talk, which will be a recording by Dr. Swati Kaliki. Dr. Swati Kaliki is the head of ocular oncology at the LV Prasad Eye Institute at Hyderabad, India. She is an extensively published person in clinical research in retinoblastoma and a recipient of several national awards for her contribution to the subject. The Southeast Asian region from where she comes represents a significant global burden of retinoblastoma, often with the problems described earlier of delayed diagnosis and advanced disease in these low and middle income countries. She will be discussing with us factors which impact outcomes in retinoblastoma in the region and strategies to overcome them. Thank you. And Anelia, if we can have the recording.
Hello, everyone. First of all, thank you for inviting me to present in this forum. It's part of this program. I'm Dr. Swati Kaliki from the Operation Eyesight Universal Institute for Eye Cancer at LV Prasad Eye Institute, India. And today I will be talking to you about retinoblastoma in Asia. I do not have any financial disclosures to make, and these are some of the abbreviations that have been used in the presentation. Now, this is a very nice article that was published by Dr. Kivella a few years ago, which talks about the epidemiological challenge of the most frequent eye cancer in children, that is retinoblastoma. The magnitude of retinoblastoma is such that there are about 7,000 to 8,000 new cases that are diagnosed every year worldwide. Unfortunately, of these, almost 50% of them die every year. But there is a great disparity in the death rate in various continents. As can be seen here, it's only about 3% in North America, 5% in Europe, 70% in Africa, and 42% in Asia. Now, when we look at the top countries where most number of retinoblastoma cases are diagnosed every year, it can be seen that most cases are diagnosed in India and China, followed by other countries. And of the top 12 list of the number of cases that are of the highest number of cases presenting per year, it can be seen that almost there are 6 countries from Asia, indicating that there is a huge burden of retinoblastoma in Asia. Now, this is a nice analysis that was done by Chen et al., where they studied the global, regional, and national burden of retinoblastoma in infants and young children. And the study period was 1990 to 2021. And according to this analysis, it was noted that there is an increased incidence and prevalence of retinoblastoma over the years in East Asia, and there was decreased rates of mortality and disease-adjusted life years in East Asia. A few years ago, we, as part of the Global Retinoblastoma Study Group, we wanted to study if there is any difference in the presentation of retinoblastoma based on the national income level. And as expected, it can be seen that almost 50% of the patients that were enrolled in the study were from Asia, indicating the huge burden of the disease in Asian countries. Now, it's very important to understand if there is a difference in the presentation based on national income status. And based on the study that was performed by the study group, it was noted that the age at diagnosis of retinoblastoma was much lower for the high-income countries at 14 months when compared to that of low-income countries, which was almost 31 months. And the patients presenting at the low-income countries, they had very advanced disease with extraocular tumor extension being noted in 49% of the cases, while extraocular tumor extension was noted only in 2% cases in high-income countries. The advanced disease can also be understood by the metastasis at presentation, and it was noted that the metastasis at presentation was 6% in low-income countries, while in high-income countries, it was very rare, it was less than 1%. Now, whenever a patient presents to us with retinoblastoma, we have to have all the treatment options available with us so that the appropriate treatment can be delivered to the patient. Now, for this, we need to understand, are all treatment options available in all the countries? The answer is a big no. Now, there are various treatment options that can be used for retinoblastoma. To summarize, these include focal treatments, which includes cryotherapy, transpupillary thermotherapy, and laser photocoagulation. Chemotherapy, which can be delivered in various forms, that is intravenous chemotherapy, periocular chemotherapy, intraarterial chemotherapy, intravitreal chemotherapy, and intracameral chemotherapy. Radiotherapy, which can be external beam radiotherapy, which is rarely used these days for intraocular retinoblastoma. The second form of radiotherapy that is very useful is plaque radiotherapy. And surgery, the most commonly performed surgery for retinoblastoma is enucleation, and very rarely patients require orbital exenteration. Now, let us understand what forms of treatment are available in different countries. Now, if we look at the laser therapy, now, where do we use this laser therapy? Now, here is an example. So if you look at the picture to the left, it can be seen that there are 2 lesions that are present in the post-equatorial region above the superotemporal arcade. And these lesions can be easily treated with laser, especially the transpupillary thermotherapy. And it can be seen that transpupillary thermotherapy was performed in this eye, and there are flat scars a few weeks after laser. However, this form of useful treatment is not available in every country or every center in the country. For example, it is available only in 46% of the centers in the low-income countries, while it is available in 99% of the centers in high-income countries. The next local treatment is cryotherapy. Now, cryotherapy is very useful for small tumors that are present in the pre-equatorial region. For example, in this picture in the left, you can see that there is a small tumor that is present almost near the aura, and there is another small tumor that is present in the posterior pole. The lesion that is present near the aura can be treated with triple freeze-thaw cryotherapy, while the lesion in the posterior pole can be treated with transpupillary thermotherapy. However, cryotherapy is not available in all the centers. It is available only in about 30% of the centers in the low-income countries, while it is available in 99% of the centers from the high-income countries. Now, next, coming to intravenous chemotherapy. Now, intravenous chemotherapy is a very useful form of treatment where 3 drugs are commonly given, that is vincristine, etoposide, and carboplatin. And these can be used for huge tumors, but without the optic nerve extension or the choroidal invasion. Here is an example where there is a huge tumor filling the eye, and intravenous chemotherapy was given to this child, 6 cycles of intravenous chemotherapy. And the tumor has nicely regressed into a type 1 regression with complete calcification. Fortunately, intravenous chemotherapy is available in most of the centers belonging to all income status, including the low-income countries, where it is available in 94% of the centers. Next, the intra-arterial chemotherapy. Now, intra-arterial chemotherapy is a specialized form of delivery of chemotherapeutic agent via the ophthalmic artery into the eye. It can be used as a primary treatment and is also useful as a secondary treatment when intravenous chemotherapy fails to control the tumor. Here is an example where intra-arterial chemotherapy has been used as a primary treatment. So that the active tumor can be seen on the left side of the picture, and the regressed tumor after the 3 cycles of intra-arterial chemotherapy can be seen towards the right. However, the specialized form of treatment is not available in many centers. It is available only in 2% of the centers belonging to low-income countries, while high-income countries, it is available in about 89% of the centers. Next, the intravitreal chemotherapy. Now, intravitreal chemotherapy again has become a very important form of chemotherapy in the past 10 years. It is mainly used to control the vitreous seeds. For example, in the left picture, it can be seen that there are 2 solid regressed tumors, but there are vitreous seeds that are present above and below these tumors. Now, for this, intravitreal chemotherapy was given, and after the intravitreal chemotherapy, it can be noted that the tumors have completely regressed. However, intravitreal chemotherapy is not being practiced in many countries. Now, it is being done only in about 28% of the centers belonging to low-income countries, while in high-income countries, it is being done in almost all the centers. Plaque radiotherapy, again, it can be used as primary treatment, but more commonly it is used as a secondary treatment when other treatments fail. For example, in the picture to the left, you can see that within the large area, there is a small area of recurrence that is in the inferior half. And for this patient, plaque radiotherapy was applied, and you can see that the tumor completely regressed after plaque radiotherapy. However, this useful form of treatment, again, is not available in many countries. In fact, it is available in less than 1% of the centers in low-income countries, while it is available in 81% of the centers belonging to high-income countries. External beam radiotherapy is rarely given for intraocular retinoblastoma these days. However, it is required for the treatment of the disease with extraocular extension. These patients have to undergo chemotherapy, followed by enucleation, followed by external beam radiotherapy, and then followed by adjuvant chemotherapy to improve the survival chances in these children. Here is an example where the child presented with extraocular tumor extension in the left eye, and this patient underwent chemotherapy, enucleation, radiotherapy, further adjuvant chemotherapy, and then a prosthetic eye was fit. And this child is doing very well at 10 years follow-up. However, the external beam radiotherapy is not available in many centers, especially in the low-income countries, where it is available in only 40% of the cases. However, the need for the external beam radiotherapy is high in the low-income countries. That's mainly because there are many more patients who present with extraocular tumor extension in these countries when compared to that of high-income countries. Enucleation, as I mentioned, is the most commonly performed surgery for retinoblastoma. And fortunately, enucleation expertise is present in almost all the centers across the world. Now, why is it important that we need to understand what facilities for treatment are available? That's mainly because even if the patient presents early to us, if we have to improve the outcomes in retinoblastoma, it is very important to have affordable, accessible, and available healthcare. Unless all these criteria are satisfied, the outcomes may not improve. So we also studied, as part of the global retinoblastoma study group, we studied the outcomes, the 3-year outcomes of the same patients that were earlier studied for presentation. And it was noted that there was a great disparity in the survival of children, and it mainly depended on the national income level of their country of residence. So the disease-related mortality was seen in 43% of the cases who belonged to the low-income countries, while the mortality rate was very low in patients belonging to high-income countries, where it was less than 1%. Now, why is it that, can we apply the same rule to Asia? Now, Asia, I think, is very unique when compared to other continents. That's mainly because the Asian continent, it has a combination of high-income countries, upper middle-income countries, lower middle-income countries, and low-income countries. And thus, the outcomes cannot be grouped into one category. It might depend upon the national income level of each of these countries. So to understand what is the presentation and the outcomes of retinoblastoma in Asia, we went ahead and studied 2,112 patients belonging to 33 Asian countries, and divided the regions into Central Asia, East Asia, South Asia, Southeast Asia, and West Asia. Now, if we look at the age at diagnosis, the delayed presentation was seen in South Asia and Southeast Asia when compared to that of the other parts of Asia. And advanced disease again was noted in South and Southeast Asia when compared to that of the Central, East, and West Asia. On the similar lines, metastasis at presentation was highest in Southeast Asia and South Asia compared to the other regions. What treatment options were available in these Asian countries? Now, the laser therapy was again not uniformly available in the entire Asia. It was available only in about 75% of the centers in Southeast Asia, 69% of the centers in West Asia. While the availability of laser therapy was better in East and South Asia, where it was more than 95%. Again, cryotherapy availability was limited in West Asia at only 69% of the centers actually having access to it, while in Southeast Asia, it was available in only 73% of the cases. Central Asia also had the availability of cryotherapy in only 42% of the centers. While in East Asia, cryotherapy was available in 93% of the centers. Intravenous chemotherapy was available in almost all the centers across Asia, which is good development. However, intra-arterial chemotherapy, again, it was poorly available, with only 2% of the centers offering the IAC services in Central Asia. And in Southeast Asia, it was available in only 24% of the cases. Intravitreal chemotherapy, it was available in only 24% of the centers in Southeast Asia, while it was better available in East Asia at 94% of the centers performing these procedures. Now, plaque radiotherapy, again, it was poorly available in Central, East, and Southeast Asia, all of which had availability less than 10% of the centers. Even in South and West Asia, the availability was less than 50%. External beam radiotherapy, again, the availability of this was limited, with only 62% of the centers in Southeast Asia having access to external beam radiotherapy. Central Asia had availability and accessibility of external beam radiotherapy in 95% of the centers. Enucleation could be performed in all the centers across Asia. If we look specifically at the disease-related mortality, the mortality was highest in Southeast Asia at 22% and least in East Asia at 4%. In West Asia, it was 11%, South Asia at 15%, and Central Asia at 13%. So in conclusion, if we study retinoblastoma specifically in Asia, it was noted that there was significant heterogeneity in treatment availability in Asia. There was significant heterogeneity in treatment outcomes in Asia. East Asia displayed better outcomes, while Southeast Asia had poorer outcomes when compared to other regions of Asia. If you want to read this article in detail, it is available on PubMed. It was published in Ophthalmology last year. You can access and read about it in detail. So thank you very much for this opportunity. And if there are any questions, I can always take them on this email. That's kalikiswati@yahoo.com. Thanks again.
Thank you, Dr. Kaliki. This was a really eye-opening talk on the perspectives and outcomes and the ground realities of retinoblastoma in Asia. And the whole thing is, one of the phrases that Dr. Swati used is what determines the outcome, that the treatment should be affordable, accessible, and available healthcare. So thank you, Dr. Swati, and I hand over to Dr. Sagir to continue further. Or Dr. Godfrey, yeah.
Yeah, no, it's okay.
Yeah.
So, but I haven't seen Professor Jessie Berry yet. Is she here, or is her talk?
I think it's a recording.
Yes.
Okay. So yeah, it's my honor and pleasure to present Professor Jesse Berry, who is a professor of ophthalmology. Okay. So and also the director of ophthalmology oncology in the Children's Hospital of Los Angeles, University of Southern California, Roski Eye Institute. She graduated from Harvard University, and after that, she went to Children's Hospital of Los Angeles, the Eye Institute there, and then received training, and her specialty is in the eye oncology. So, Professor Berry.
Good morning, wherever you're joining today. I'm Jess Berry, and I'm the Director of Ocular Oncology and the Retinoblastoma Program at Children's Hospital Los Angeles. And I'm so delighted to be here today to discuss some exciting new research in retinoblastoma from our laboratory and hospital, which we call Liquid Gold, a new era of molecular diagnostics for retinoblastoma. I do have research funding, which is listed here, but I do not have any relationships with ineligible companies who sell or market products for patients. So today we're going to talk about biopsies and liquid biopsies. What is a liquid biopsy and why is it needed? What have we learned by using a liquid biopsy platform, and what does the DNA tell us? What is the status of current clinical testing for RB? And are there other biomarkers outside of DNA? So I always like to start this talk by really setting the stage, particularly for ophthalmologists and who do not sit and think in the cancer world in the same way that my oncology colleagues do. Cancer medicine has become precision medicine. And what does that mean? That means using specific information about a person's tumor to help make a diagnosis, better understand the prognosis of that cancer, or to plan various treatment regimens based on those tumor-derived biomarkers. And in fact, this is such a important initiative that the National Cancer Institute and the Children's Oncology Group have made a pediatric match trial with a simple but profound goal of sequencing and understanding the DNA structure and the biological markers of each pediatric solid tumor. And as you can see by this video here, cancer medicine and precision medicine is not a one-off for one or two tumors. Multiple tumors have precision medicine treatment and multiple types of precision medicine treatment for each kind of tumor. Children's oncology is catching up here, both in terms of liquid biopsy as well as precision medicine, but this is a profound and important goal. So if this is so important and there's such a push towards it, why then is there no precision medicine for the most common pediatric intraocular tumor? Well, the answer here is quite clear, right? It is long-standing been a tenet and remains a tenet that you do not biopsy an eye with retinoblastoma. And of course, this comes from multiple very good studies as well as inadvertent attempts to biopsy an eye that maybe was thought not to have retinoblastoma, and seeding of that retinoblastoma tumor from inside the eye moved to outside the eye, which dramatically changed the child's prognosis for life. So we do not biopsy retinoblastoma tumors. But if you can't biopsy, meaning you can never attain these markers that drive precision oncology care, are there alternatives like a liquid biopsy? So first, what is a liquid biopsy? It is a biospecimen. It can be CSF, very commonly it's blood. It can even be urine, pleural effusions, or ocular fluids like vitreous and or aqueous. And generally it's a mix of cellular or non-cellular components. And ultimately, while it is not the tumor, you are getting information from the tumor in that liquid. And liquid biopsies were described way back in the 1980s, but specific mutations and tumor-derived markers were not described until the 1990s and early clinical tests in the 2000s. And while a tumor biopsy will give you a snippet of what's going on in one part of the tumor at one single time. The idea behind a liquid biopsy is that you're seeing all of the clones and variations within the tumor, and so you're seeing a more complete picture, a more robust picture of that tumor. And further, in general, liquid biopsies are repeatable. So longitudinally, you can see how that tumor is changing at a molecular level. And so what started with a crazy idea is now 7 years gone by. In 2017, our laboratory at CHLA was the first to introduce the concept of using the aqueous humor, or the clear fluid in front of the eye, as a liquid biopsy for retinoblastoma. And you can see here in this procedure, this is us taking the aqueous, which was initially done as part of intravitreal injections of chemotherapy, as you see right here. This study of the aqueous has led to an explosion of research around the world in the last 7 years. And from a crazy idea, it is now well established and accepted that the aqueous humor is a robust source of cell-free, not cellular, cell-free tumor DNA. And so this is a brief timeline of our aqueous humor work, which I'm going to go over, and happy to share any of these papers if anyone is interested in delving in deeper. But in 2017, we described the potential of the aqueous. It's basically a case report, or small case series. We then were able to show that you could compare the genomic alterations in the aqueous humor from eyes that had been saved to the genomic alterations from eyes that had been enucleated, to show that the genomics mattered and that there was a specific difference that you could identify. That specific difference that we found was something called 6p amplification, or high-level 6p gain. Not a little bit, not one extra copy of 6p, but multiple extra copies of this genomic region in 6p, whole 6p gain, tended to show prognostication for eyes that failed treatment and needed enucleation. This was a big and exciting finding, and something that we could not have done previously, because previously you only had this information if the eye had already been enucleated. So now we were identifying molecular markers for ocular salvage, prognosis for ocular salvage. We then went on to show that not only can you find these genomic markers, but also you can identify the specific RB1 mutation or mutations, the reason for both hits in the RB1 gene that is driving the tumor. And we found also that you can identify these alterations over time. So at the time of recurrence, there are different alterations, usually 1 or 2 new alterations, and it's possible that with further study, we'll understand if those alterations are driving tumorigenesis. Another really interesting piece from this research is that, as clinicians, we knew that if you treated one child that had tumors in both eyes, sometimes the eyes would respond really differently, even in the face of the same treatment. Well, we've now been able to show that these tumors are distinct, different tumors at a molecular level. Although they have the same initial germline RB1 mutation, the second hit, as well as the chromosomal alterations that drive tumorigenesis, are different in these patients. And so this likely at a molecular level explains what we see at a clinical level, why one eye might respond differently than another in the same child. And then we opened our research to multi-center and started to receive samples and data from other centers in the US and around the world. This is an ongoing and extremely exciting initiative. For us to best understand retinoblastoma, we need to see multiple treatment regimens, and we need to capture kids from all over the world. And so we're now doing this. This first multi-site paper was in preparation for clinical testing to better understand the levels of DNA you can get in the aqueous at various times. And then finally, we just recently published our 5 years of progress paper in preparation for clinical testing, which I'll touch on at the end. And so, as I mentioned, we have gone beyond USC and CHLA in order to capture patients with retinoblastoma all over the world. And this is an open protocol. We're always excited and open to working with sites around the world. There are sites listed here, but as of today, we actually have 31 sites that are at some level of commitment of sending us samples or data. And so before I go on any further, I'd like to just take a brief moment to go over the lingo of how we detect tumor DNA, because there's two different ways and it's important. The first is whole genome sequencing, which literally means that you do low pass, meaning light sequencing along the whole genome, looking at all of the chromosomes in the DNA that you can find. And you're looking to see if there's too many copies, too many or too few copies in certain chromosomal regions. You need about 5% of tumor DNA to really start to see these differences, but a really low level of sequencing can give you some really impactful data. So if you don't have a lot of DNA, you can still get some really important data. Then there's targeted sequencing, where you look just at one gene and you sequence it many times. So not light sequencing, but really deep sequencing of a certain region. And again, for retinoblastoma, it makes sense you'd use RB1. And here you can find a alteration down to like 0.01%, a needle in a haystack, but you need a lot of DNA or a lot of input in order to do that. And so there's our needle versus the haystack. So from all of this information in the last 7 or so years, what have we learned? So first, and this is simple but important to state again, we've learned that there's tumor DNA in the aqueous humor. You can see here, these are areas of gains and areas of losses in low-pass whole genome sequencing that we identified from the aqueous. This was in 3 cases early on. And we were able to compare this to other studies that had been done from tumor tissue in enucleated eyes. Previously, again, the only way you could do this. And I think you can appreciate here that the overall shape is similar. We were detecting these recurrent alterations that are consistent with retinoblastoma. And then we were able to compare groups of patients, groups of a patient group who did well, whose eye was saved with therapy, versus a group of patient who failed therapy and their eye needed to be removed. And as you can see in this early paper, we had 13 eyes enucleated and 16 eyes salvaged. And what we found here very dramatically is that the eyes that failed treatment had a lot of copies of 6P gain. So high level 6P gain here. And not only did we find that, but we found that it really seemed to matter. These are Kaplan-Meier curves of ocular salvage, and eyes with 6P gain tended to fail treatment and be enucleated. If we look at all eyes, if we look just at group D eyes, or if we look at CT2B eyes, no matter how we classified the eyes clinically, 6P seemed to matter. And in fact, it had a 10 times increased odds of failing therapy and needing enucleation. We also found that tumor fraction, or the percentage of tumor DNA in the aqueous, also mattered. And so if you look at this patient here, this patient was getting injections for seeding in the eye, and at injection 1, a very altered profile. If you take nothing else from this lecture, this should scream lots of active tumor when you see a profile that's all over the place like that. But with injections, this tumor profile starts to normalize. And clinically, if you look down here at this fundus photo, the patient's doing better. However, if you start to follow tumor fraction, at visits 4 and 5, this tumor fraction starts to increase. I hope you see that right there. I looked okay clinically when we looked in, but the aqueous was telling a different story. And in fact, at injection 6, there was a huge recurrence. You can see here, tumor fractions now through the roof. You see these alterations again. So following tumor fraction can give us really important information that may be better than what the clinician sees themselves. You see those early bumps right there. So what about the blood? Well, there's been very exciting data out of Curie and Sloan Kettering that has shown that you can detect retinoblastoma tumor-derived DNA in the blood, generally in very advanced eyes with large tumors. And you can find this RB1 alteration. So these blood studies are, again, looking for that needle in the haystack. They don't have a haystack of DNA. They don't have a lot of tumor DNA, but they can go down and find teensy tiny amounts. They've shown that it plummets to undetectable after 1 cycle of chemotherapy. And that, in fact, if the fraction of tumor DNA in the blood stays elevated, it may predict metastatic disease, although that's in a small number of patients at this point. And if a patient is untreated, the blood may show an increase in tumor DNA. And so should we just abandon the aqueous humor then? Well, of course, I guess I'm a little biased because I started this area of research, but we did a head-to-head comparison of the aqueous and the blood. And this is what we found. In a head-to-head comparison, You cannot find the same level of chromosomal alterations in the blood versus the aqueous. You only find this level of molecular detail to see 6P and other markers when you look in the aqueous humor. And so to me, I think the blood plays a really important role for the body and risk of metastatic disease. The aqueous plays no role there. But if you want to know what's going on at the level of the tumor, you need to get close to the tumor and you need to look in the aqueous. As I've already mentioned, we have identified that in bilateral disease, each eye has independent markers. This is another reason why the aqueous is superior to blood. Blood is not going to show you DNA from right eye and DNA from left eye. So again, 2 tumors, 2 eyes, you need to go to the aqueous. And so here you can see a right and a left eye. The left eye shows that high level 6P gain there, right there. And you can imagine that even with the same treatment, this is the eye that did not respond quite so well. You can also track the tumor fraction as mentioned and show a tumor fraction going from almost 80% down to less than 10%, and this eye was ultimately saved. So with all of this information, we combined with our clinical laboratory at CHLA and said, we really want to move this into the clinical space and out of the research lab. They decided that this was a great partnership, and so we worked together and developed a clinically validated test called LB-Seq for Kids, which is validated for use in CSF blood and aqueous humor. And there was a lot of fanfare and a lot of press around this, specifically because, as I mentioned previously, there are some liquid biopsy options in adults, but fewer in children. So this was a big step forward, regardless of tumor and regardless of substrate. And so it's always nerve-wracking to move from a research laboratory where you have a set SOP and protocol into a new, completely different laboratory, but we were able to do that in the, again, clinically validated lab. And we included 136 different genes because, again, the idea is that this can be used for retinoblastoma, but also other pediatric solid tumors. And you can see the ones that relate to RB1 here. And so what are some important clinical questions we've been able to answer? Well, the first is pretty straightforward, but can we use the aqueous for molecular diagnosis? And the answer is quite clearly yes. And so you may see these 2 patients who have retinoblastoma, and the diagnosis for someone who does retinoblastoma is pretty clear. And it doesn't take an advanced retinoblastoma surgeon to tell you that this eye is likely to do better than this eye, right? There's more tumor, you can't see ocular structures. It's pretty obvious. But what about these 2 patients? Maybe a molecular diagnosis here would be helpful. Do both of these patients have retinoblastoma? And if they do, which one is going to do better? I'll tell you, one of them does not. And what if we can't see well into the eye? So almost everything we do as ocular oncologists is predicated on vision, on us seeing in. And so if there's a cataract or vitreous hemorrhage, or if you see a big detachment with yellow debris, but there's no actual ocular mass in the eye, this can be difficult. And in fact, in many centers, including at our center until recently, an eye might be enucleated to be safe, to be sure it doesn't harbor retinoblastoma. Well, now we have a molecular diagnostic that can be used clinically. And so instead of an enucleation, you can do a paracentesis. Let's start with some of our results. So for RB1 mutations, we are at about 86% detection. That's pretty good. We're continuing to work to make that even stronger. The patients who weren't detected generally had a smaller tumor. And so if you add on chromosomes, so again, the 2 ways that you can find tumor DNA, and you do that low pass whole genome sequencing, and you include larger tumors, so 3 millimeters or larger. 3 millimeters is still really tiny. That's group B. We were able to then detect tumor DNA in 95% of eyes at diagnosis in the aqueous humor. And here are some results from this, from the clinical test. This is a child, 1-year-old male, bilateral retinoblastoma. You can see here, these 2 profiles look different. There are unique and distinct alterations in each eye, consistent with primary bilateral tumors. Can we use the aqueous to guide prognosis for treatment response? So, we've discussed how 6P matters. We found that this high level 6P gain really does seem to be impactful. These eyes recur. They can recur late, and they can recur, yes, both after systemic chemotherapy as well as intraarterial chemotherapy. So we can follow these prognostic biomarkers and also follow for response to treatment. So this is a 1-year-old female, has retinoblastoma in the right eye. You can see these alterations. This is low level 6P gain, so not high level. You don't see that big spike there, but you see there are other alterations. And at the end of therapy, we repeated the LB-Seq for Kids aqueous humor liquid biopsy. You can see here a nice flat profile. This is consistent with complete therapy. Now, you look in this eye, it looks much better, obviously, but there's still some vitreous haze. There might be some questions. So this can augment what we see clinically. And this is in comparison to another child, a bilateral retinoblastoma in a 2-year-old male. At diagnosis, you see multiple alterations, including here in the left eye, 6P gain that was not present in the right eye. At the end of therapy, after 6 cycles of systemic chemotherapy, we can evaluate for active disease. And again, the right eye still looks a little hazy, but nice, clean profile there. Stable eye. The left eye shows mostly calcified seeds here, and we think calcified seeds are dead, but definitely there's some schmutz, that's the medical word, I guess, in the aqueous there. And in fact, this correlates with what we see in the molecular profile in the aqueous. This is still an eye that's active. And in fact, this eye remained active for quite a long time. This is another really important test of the aqueous, and we can accept samples from other centers, and I will tell you this is the #1 question that other centers are asking. I can't see into the eye anymore. Is there still active disease? So this was a pretty dramatic case, but this is a patient who had been stable for a very long time and then presented with blood in the eye years after being stable and the end of treatment. The ultrasound, the tumor measured stably. It didn't look like there was a big change. There's lots of various vitreous opacities here. Is this tumor recurrence? Is it seeding? Is it blood? It can be very hard to tell. So we did the aqueous humor liquid biopsy, and you can tell here this is very positive. So we discussed with the family, we moved forward with enucleation, and in fact, pathology confirmed a large intraocular recurrence. It was all hiding under the calcium, so you couldn't see it very well on B-scan. And also we know that MICN alterations are consistent with aggressive pathology and aggressive retinoblastoma disease. Can we use the aqueous to identify that? And the answer is yes. These are 3 cases, but you can see here, this is high-level MICN amplification. That's the single gene region, which is why you see a little spike there. Now, positive tests matter, but what about a negative test? Well, we know that these matter as well. This is a patient who was seen at an outside hospital and planned for bilateral enucleation for presumed bilateral intraocular RB with poor vision. You can see, however, that in fact, this patient does have masses in the eye, can't see so well. You see some white or yellow debris, but is this retinoblastoma? Well, if you look at the other eye, you might start to think, oh, I'm not sure if this is retinoblastoma. And in fact, there were no alterations and no RB1 gene mutations found in the aqueous humor. These profiles are not consistent with RB or malignant process, and this in fact ended up being fever with bilateral retinal detachment. So far to date, we've had 50 aqueous humor samples. We've actually had nearly 100. I just need to update this slide, but 50 is a good number to sit at for now. And for patients, overall, we say that our feasibility is greater than 95%. We had enough DNA in 48 out of 50 samples in order to run the test. In terms of retinoblastoma at diagnosis, we had 100% detection rate. Retinoblastoma, pseudoretinoblastoma, not retinoblastoma, but fever or coats or other diseases, it was negative 100% of the time. We had 1 false positive for a retinoblastoma presumed to be in remission, and we're actually still working this case up. So we'll see what this one ends up being. So it will not always end up being this great, I presume, but right now our sensitivity is 100% and our specificity is 95%. That's pretty good. And have we learned anything about safety? Well, from our center and some other centers in the United States, we had 606 samples. That was 251 eyes, 7 surgeons, and 5 hospitals. And we use a 32 gauge needle, so a needle about the size of a human hair, to take the aqueous humor. And there's not a grading system for paracentesis complications, so we made one. Mild meant eyes that basically had something that was transient but didn't affect long-term vision or long-term eye, and no intervention was needed. Moderate, an intervention was needed, but overall the child's vision, eye, and life remained stable. And then severe was something that threatened those things, threatened vision, threatened globe salvage, or threatened life. And what we found is that there was one mild complication, which was a subconjunctival hemorrhage that was seen 48 hours after paracentesis without other trauma. That subconjunctival hemorrhage, of course, went away on its own and caused no problem. We've actually broadened this to some of our other sites, and we have a paper under review with greater than 1,200 samples, and the number of complications remain the same. So overall, we're at a very low complication rate, about 1 in 1,000. Now, aside from DNA, what else can we find in the aqueous humor? I'll just touch on a couple of things in the last 5 minutes. So methylation, we know, is the mechanism that tumors use to turn genes on and off. So good genes get turned off and bad genes get turned on, and the cancer becomes more aggressive. And so we identified that we can actually find the methylation of these genes using the DNA in the aqueous humor. There's enough there to do this. So this is 4 aqueous humor tumor pairs, and you can see that they are correlating together, but that they're different. This is good. So what you find in the aqueous is representative of tumor, but these signatures vary and the variation might matter. From these genomics, we identified the TFF1 gene as a potential prognostic biomarker in retinoblastoma, and other centers have done the same. So really beautiful high-risk retinoblastoma subtype paper. I recommend everyone read it. You might have to read it 10 times. It's dense, but it's a great paper. Also identified TFF1, and you can see our liquid biopsy did as well. The team out of Germany also found that you can use TFF as a single biomarker in the aqueous, which is potentially predictive. And then tumor studies have similarly shown this. So this is the way in which new information is getting out and being tested across the world from this aqueous humor. And aside from DNA, there's also extracellular vesicles. These are small membrane-bound molecules. We think that they play a role in intercellular communication. They've definitely been shown to play a role in other cancers. It's crazy that we're watching each other through these little vesicles floating around in the aqueous, but a lot more work to be done. We have been able to show that the vesicles in the aqueous show a CD63 predominant signal, and that's unique to the eye in the aqueous. Lots more work to be done here. And so I'm going to just end by showing an application of LB-Seq for kids outside of the eye. So let's meet Mark. This is a child who I have permission to share his story from his parents. He was diagnosed with unilateral RB at 6 weeks of age and was enucleated. There was high-level 6P gain. He had a germline RB1 alteration and developed a pineal cyst, which was monitored, and unfortunately developed into a pinealoblastoma. What can liquid biopsy teach us about Mark's disease? So here he is with the pineal cyst. The MRI remained stable, and then he developed vomiting. And at that point in time, his MRI showed that, in fact, this was a pinealoblastoma that had formed. CSF was taken at that time and showed no cells, but it was positive for LB-Seq for kids, showing tumor DNA in the CSF. He underwent surgery and high-dose chemotherapy and bone marrow transplant. His MRI after therapy was called no evidence of disease. His cytology showed no cells. However, his CSF remained positive on liquid biopsy for circulating tumor DNA. His spine on MRI at that time was also clear of disease. So what do you do when the gold standard results don't jive with a new test? And the truth is, no one knows. This still requires study, and no one exactly knew what to do after the strongest chemotherapy agents that could be given made the tumor go away, but there was still this signal in the CSF. Was this dead cells? What does it mean? So we monitored. We did another MRI in March and May. There was no evidence of disease, cytology, no cells. LB-Seq for kids was still positive. And you can see it was not a little positive, it was a lot positive. And there's our 6P gain. And in June 2024, Mark developed somnolence and was identified at that point in time to have recurrent pinealoblastoma with some bleeding. There were no trials. He was started on palliative therapy. His spine now showed disease. In July 2024, his disease was progressive despite this palliative therapy, and we lost Mark in August of 2024, just months ago. And so, can we implement this technology for future babies like Mark or other children who might need this kind of therapy, who might benefit from us following the CSF? Could we have maybe detected something at the time there was a pineal cyst? Are there better therapies at the time that the CSF remains stable and we're seeing this tumor DNA, but all other studies point to no evidence of disease? There's so much to research here and so much that's yet unknown. This is one really powerful and impactful case, and I'm so grateful to his parents that they allow me to share this information, but we don't know yet. More to come, but we have a new impactful clinical technology that may help us. And so to end, how do we see aqueous humor or other liquid biopsy tests making an impact in the future? Well, we have some proposals for a prognostic biomarker-driven clinical trial where you can take the aqueous and the blood, see whether or not these more prognostic biomarkers like 6P gain or MYC amplification are present, and if they are present, escalate to more aggressive therapy. This is personalizing the treatment for intraocular retinoblastoma. Or you can go on to follow tumor fraction and imagine a setting where you follow these children until the tumor fraction, both in the blood and the aqueous, is negative, suggesting complete clearance of active disease. Another way you can personalize medicine with the aqueous humor and other liquid biopsies. So in 2024, what's the role of a liquid biopsy? Well, it's still under a lot of active research, but thankfully we now have a validated clinical test that uses the aqueous humor to give some information about the eye. This can help us detect RB1 mutations as well as prognostic biomarkers. If anyone's interested, I can share this video where we go through the actual protocol of this, and just reach out to me. Happy to share at any time. This is my liquid biopsy and clinical team. I don't do any of this work alone. I'm so grateful to them for believing in this crazy idea, 7 or so years ago, and really bringing this forward to make the future of care for children with retinoblastoma better. And always to my mentor, Dr. Lynn Murphy, who taught me everything I know about retinoblastoma and was just the kindest person ever. Thank you so much. If there are any questions at all, I am happy to take them. Thank you.
Thank you, Professor Barry. This is a wonderful talk, very innovative approach to retinoblastoma. So I think we still have a few minutes for the discussions, right? So any questions from the floor?
There was one question in the chat by Suzanne. It's for Guillermo about convincing the governments for screening programs for retinoblastoma.
Screening program, yeah. Yeah, Professor.
Yeah, I'm reading the question. Yes, thank you, Anne. It's nice to meet you again today. I was not successful, and I learned from them. I think they are right. We shouldn't do screening of retinoblastoma in the general population with the tools we have now. I tried 2 times, in fact. And for the reasons I mentioned, I think we have to first deal with the time to treatment, time to diagnosis, reducing abandonment rate. These are the low-hanging fruits. If we really want to go to the general population, we have to have these factors already fixed, because it wouldn't make sense to pick a case early and then to wait 6 months until the child gets to treatment or doesn't have any chemotherapy drug, or then the family does not accept the nucleation. So I think in a priority, I would start with those factors because, again, it's a rare tumor. We don't have a reliable test, and we don't have the human resources to really perform the diagnosis in a timely fashion.
I
Right.
have a questions for Professor Barry. I hope she's still around. How much volume of aqueous tumor actually can be aspirate? Because of course we can do many tests because she did mentions the cell-free DNA, the methylation profiling, and also the cellular molecules, the exosome, etc. So I mean, how much volume can we get from the?
Godfrey, I think she's not with us right now.
Oh, this is not around. Okay.
Yeah.
No. So any questions for the other speakers?
So, Gulmo, about the strategies for in Latin American countries for screening during immunization, and there are some publications also. So I don't know, internationally, these has been tested somewhere else also, or it was, it was really exciting that they were doing all kids coming for vaccinations. They were just evaluating for, just a screening for retinoblastoma. So what's your take on that?
Yeah, I think you mentioned the experience in Honduras, and
Yes, yes.
it was, in fact, what they did was during the vaccination at the first year, they give a pamphlet to the parents, and so just to make them aware on retinoblastoma. They didn't do any actual physical exam. They just did disease awareness, which I think it's okay. And it's a different story compared to screening. Screening is like mammography. You have to go to somewhere, you take a test, and then if you have the positive test, you go to diagnosis in a center, and then you do the diagnosis. So it's that's why I think we are using the word screening too loosely, and these are probably two different things. And again, as I showed the picture, I traveled 3 hours to go to a disease awareness thing in Rio de Janeiro. So I'm not opposing to that. I'm just saying that screening is a different story, because screening, you need to go to the general population. There is a false negative, false positive, and the risk of doing screening compared to not doing screening for people that don't have the disease. So I think it's a different story. For the Honduras study, I still have. So we discussed a lot with Ligia Fu and the people in Honduras, because their number of extraocular cases did not drop. They had more intraocular cases, but not less extraocular cases. It was not a population-based data, so you don't know if you were seeing more intraocular cases because they were treating somewhere else, or they were really making an impact, because the number of extraocular was exactly the same. So I think if we want to do screening, I failed to convince the authorities, and as we say in Spanish, we learn with a stick. They say go there and check what we do in breast cancer, check what we do in cervical cancer, and we still have I still think we there might be a way if we have a better test. If the cell phone applications with the artificial intelligence improve, and you can just take a picture and really make sure that that retinoblastoma or any other eye condition, I don't know, and you're really getting there easily with a good test, etc. I think even for a rare tumor, we can make an improvement. But I would start first with the rest. Yeah.
Yeah, thanks a lot. So I think
Yeah.
it's getting a little bit late. I think Puna is around, right? Puna will give us a closing remark. Yeah, thank everyone for the contribution tonight. Yeah. Puna, can you
I'm unmuted. Okay. Thank you very much, Godfrey. And on behalf of Asian Pediatric Hematology Oncology Group, which is an academic and research wing of SIOP Asia, we thank all the speakers for this excellent coverage of this topic, which is so relevant for Asian subcontinent, being a common solid tumor with a higher mortality as opposed to the Western or developed countries where it is lower in frequency and with a very high curability. We went through the whole gamut of presentations, starting with way of treating and also the Asian scenario which Dr. Kalki highlighted, and to the research mode of Professor Berry, who showed us a new path as to how we can further stratify or look into the prognostication and follow-up of such tumors. So we really had a good scientific feast during this symposium, and this has been our constant endeavor with APHOG. This is the fourth in the series for this such joint symposium, and the whole idea is to carry forward this exercise to generate ideas about research, clinical as well as the lab research in the Asian subcontinent for the common and relevant diseases. And I'm sure Professor Berry's presentation has really opened up a new whole vision for all of us listening to her, that how we can collaborate and look into this aspect more closely, because we may be seeing different type of retinoblastomas who tend to be more aggressive upfront rather than so I'm sure it is going to be a very insightful research which we can generate out of this interaction. And this is the whole idea of having such joint symposium. And we will see everyone in future. And we thank all the speakers to bring up all these different aspects of retinoblastoma. And thank you very much. Good evening and good night and good morning or good afternoon across the world. Whoever is watching this, who is joined us for this interesting symposium. Thank you.
Thank you. I'll pass it back to our chairman, Akira. So, Akira.
I have nothing to say more. But anyway, thank you very much for participating in this very important and interesting joint symposium. So let's work together for the future of the Asia and the world for children. So, good night, good morning, and good
Bye-bye.
afternoon.
Thank you very much.
Thank you, Guillermo.